Good morning, Rupen. Good morning, everyone. Thanks for being here. It's nice to see you, Rupen.
Nice to see you. Thank you. I think I see our meeting host, Ariana, just joined. I think you're on mute, Ariana.
Morning, Ruben.
There you go. Good morning.
Yes. Hi, everyone. So today we will be talking about what to do when the answer is yes, talking with families about guns, vaping, and hunger. And Rupen will be guiding today's conversations and webinar. So Rupen, take it away.
Right. And can everyone see my screen okay?
Yes.
All right. Well, thank you everyone for joining us so early in the morning. And thank you to my employer, Swedish, who's facilitated helping the chapter provide CME for this talk today as well. As Ariana said today, topic of my conversation is how to respond when the answer is yes to those routine screening questions, talking to families about guns in the home, smoking, vaping, and hunger. Both the AAP and Bright Futures recommends that we screen for these three social determinants of health at every well exam. And yet I found that many pediatricians feel unconfident or a little bit uncomfortable addressing these topics with families. And I gather there's two primary reasons for that. One reason is this feeling of not being an expert. For that, I would say each of us are experts in child health and safety. And when we couch these conversations in that context, families really do trust our expertise. And the other reason I think doctors sometimes feel comfortable with these topics is not knowing for sure what the next step is when the answer is yes. You know, we do a lot of screenings in pediatrics, and whether we're screening for mental health issues or lead level or what have you, it's important that we know what to do when we get a positive screen. And these three social determinants of health are no exception to that rule. So we'll spend the bulk of our time today talking about that. So our objectives for today, recognizing the critical need to screen for these three social determinants, learning how best to ask about them, and gaining confidence in counseling patients about safe storage of firearms, tobacco cessation, and food resources. With that, I'm going to jump into our first topic. I should say I have no conflicts of interest to disclose today. And we'll start talking about firearm access. Now, in light of recent events, I think we're all feeling particularly passionate about this issue right now and hoping desperately that Congress can at least pass some of the common sense laws that the majority of Americans support. But I think it's worth noting that while mass shootings get all the media attention and renew the debate on legislation, they still have only counted for well under 1% of firearm fatalities in our country. So the interventions that we're talking about today are still critical for child health. In fact, every day, 9 children in the US are killed by firearms. And globally, 9 out of 10 children less than 15 years of age who are killed by firearms reside in the US. So why do we ask about guns in the home at our checkups? Well, about 1/3 of American children live in homes with firearms. And of those households, 43% contain at least one unlocked firearm, and 13% contain at least one firearm that is unlocked and either loaded or stored with ammunition. This is from CDC data, and the thought is this actually data is from before the pandemic, and those numbers are actually higher since the onset of the pandemic. We also know that about 80% of unintentional firearm deaths of kids under age 15 occur in a home. And suicide is now the second leading cause of death for teenagers. And the firearm used in adolescent suicide comes from the house 9 out of 10 times. And the risk of homicide is 3 times higher when there are guns in the home, with 58% of shooting deaths in children and teens being homicides. And going back to school shootings, we do know that the majority are facilitated by kids who have access to unsecured guns at home. Know that hiding guns doesn't work. Numerous studies show that about 75% of children and teens know where firearms are kept in their home, with 1/3 of them reporting having handled them, and 1/5 report handling them with no adults around at all. And those same studies show that about 40% of parents erroneously believe that their children do not know where the guns are stored, and 22% of them wrongly believe that their children have never handled the guns. We know that children are naturally curious. If a gun is accessible in the home, there's a good chance that they will find it and play with it. And kids as young as 3 years old are strong enough to pull the handgun on trigger or trigger on a handgun. So a couple tips for counseling is to talk to families about guns in the home. One, it's important to frame the conversation of safe storage in terms of risk mitigation. Just like having a pool in the backyard increases the risk of drowning, having a firearm in the home increases the risk of firearm injury. And to prevent drowning, you put the fence around the pool and put a cover on it. So to prevent firearm injury, you secure the firearm by locking it up and removing the ammunition. Studies show that parents who receive counseling from PDEC providers in those types of terms are more likely to report the adoption of safe storage practices. And counseling on firearm safety can be non-judgmental and collaborative. Research also shows it's better to use the term firearm rather than gun. That seems to elicit less emotions at the start of a conversation. Some of the best ways to ask about firearms in the home. Instead of asking, do you have a firearm in your home? You can ask if firearms are present where your child lives or plays, how are they stored? If parents say the firearms are kept away from children, explore how they are stored. If they say they're not stored away, assess why not. Identify the barriers of safe storage, like concerns about cost or accessibility. And if the family says they don't own firearms, then it's still a good time to encourage parents to talk to other family and friends about where their child visits to ask about safe storage in those homes. And I'll get in a little more details on ways to do that a little later. Allow the reason for ownership to guide the conversation. So there are multiple reasons that people own firearms. The predominant reason is personal protection, but other reasons are hunting or sport shooting, collecting, or the job requires it. So if the family's reason for having a firearm is for a reason other than personal protection, then it would be worthwhile to share that some firearm owners choose to store their firearms at local gun clubs or at local gun ranges. If the family's reason is personal protection, which will be the case most of the time, then share that research shows that a handgun in a home is more likely to injure or kill a family member than to thwart an intruder. There are safer methods for protection, including alarm systems, security cameras, floodlights, dogs, or self-defense sprays. If it's clear that a family feels strongly about storing firearms at home, then you're going to focus on safe storage. And that's primarily what you'll be focusing on in your visits. There are 3 simple rules of safe storage. 1, firearms should be stored unloaded. That means no bullets, rounds, ammo, magazines, or clips should be present in the firearms when storing. Firearms should be locked away. That means locked in a safe or lockbox or cable lock or by another method. And ammunition should be stored separately from the firearm. It should be also locked away. And a safe can work for that. This is a poster that the AP has on the website that can be downloaded and printed and posted in your exam rooms. It's a sort of simple graphic of some different kinds of storage options out there. But one that I like a lot more is from the King County Lock It Up program. For those of you who are not familiar with Lock It Up, it's a program of Public Health Seattle and King County. They do some events along with Seattle Children's, which they do free giveaways for some storage items, but also simply mentioning Lock It Up at the majority of retailers will automatically get you a discount on the storage devices. I like this one because it shows you the pros and cons of different storage devices. Again, this can be downloaded and printed for free off the Lock It Up website. Here, this shows you there are trigger locks. The advantages of those is they're affordable, they're compact. Some disadvantages is they're not theft resistant. Right? The trigger lock is on the gun can still be stolen, and some of the lower quality ones can be broken or won't fit whole firearms. It shows you cable locks. These are the ones that are usually part of the giveaway events. They can actually be free, but if not, they're still very affordable. Similar to trigger locks, though, they don't prevent theft, and some of them can be cut, and some of the lower quality ones can be. And then it shows you lock boxes and gun vaults for safes. Lock boxes are theft resistant because they can be bolted down. The cost can vary quite a bit depending on how you open them. There are digital keypads or biometric identification or just combinations, but they are also pretty affordable and again pretty compact. And then for gun vaults or safes, those are going to be much more helpful if you have multiple firearms to store or if they're long guns to store. These, of course, are a lot more expensive, but multi-use and theft resistant. So these are the different ways that you can advise people about how they can store their firearms if accessibility or cost is an issue. It's important to meet families where they are to move closer to safer. While there certainly are firearm owners who agree with the tenets of safe storage, some owners may think the recommended storage practices sound uninformed. As a provider, your job is to share relevant firearm storage recommendations in the context of injury prevention and work with the family to find a mutual solution to get to safer storage. So, for example, if locked, unloaded, and ammunition stored separately is too daunting for a family, then just taking the step of encouraging them to lock their firearms, even if loaded, is still safer than leaving the firearms unlocked and loaded. It's also important to let families know that teaching kids firearm safety isn't enough. Nearly all Americans believe that it's important to talk to them about firearm safety. In fact, gun owners do even more so than non-owners. So you'll encounter parents who are confident that their children know the rules and will never touch a firearm. But it's vital that while you show support for their intention to prevent firearm accidents, that this is not safe enough to just do the teaching. The research is clear that teaching children about the dangers of firearms does not stop them from playing with them, even when adults are not looking. There's even research looking at some avoidance programs like Any Eagle, which are designed to educate children at reducing firearm injury, and have shown that they don't really prevent risk behaviors. And in fact, they might even encourage behaviors. Children can sometimes learn the song and recite what they're supposed to do, but in the moment, the curiosity just takes over. And we all know that teens are impulsive and their moods can change quickly. And finding that a firearm is locked serves as a deterrent to use the weapon in a way that could be deadly. There are also some times when safe storage is simply not enough. If a child in the home is expressing suicidal ideation, especially if they have thought about using a gun for suicide, the advice should be to get the gun out of the home. Here in Washington State, the Harborview Injury Prevention Research Center has created an online firearm safe storage map, and this is a statewide map, which helps people in crisis identify local options for where they can temporarily store firearms, and it's typically voluntary or low cost. Lastly, as I mentioned earlier, it's important to encourage parents to ask about guns at other homes where their children will be. That's so important because more than a third of all intentional shootings of children take place in homes of their friends, neighbors, or relatives. So, and encouraging parents not only helps ensure the safety of their own child, but also promotes that dialogue in the community. The Asking to Save Kids campaign is an initiative of the Brady campaign, I'm sure we're all familiar with. And I think they do a great job of providing scenarios in which you should have this conversation and even providing sample questions. So this is taken from Asking to Save Kids. If parents are dropping off their kids for a play date, parent can say, my kid is pretty curious and our doctor recommended that I ask, is there an unlocked gun where my child will play? If a teen is taking their first babysitting job, they could ask, is there an unlocked or loaded gun in your home? If a young adult is moving into a group home, then asking, does anyone own a gun? If so, how do you store it? And also when considering the care of an elderly family member, especially those who may suffer from dementia, asking the family, do we need to think about how we safely store the guns? Those are all scenarios in which these conversations should occur, and we can encourage that. A lot to cover today, so I'm going to just jump into our next topic, and I know we'll have time at the end for questions. I want to move on to tobacco use. Again, something that we should screen for at every checkup. And I spend most of my time talking about teen tobacco use, but we'll talk about parents' use towards the end as well. So why do we ask youth about tobacco? Well, youth are uniquely susceptible to nicotine dependence because their brains are still developing. We know that nicotine can harm the developing brain, including the parts of the brain that control attention, learning, mood, and impulse control. And the popularity of the pod-based e-cigarettes that we've seen in recent years is particularly concerning. They can expose youth to higher levels of nicotine than other types of tobacco products. And the vast majority of adults who use tobacco started use when they were a teen. So early intervention is critical. We know that nicotine addiction happens more quickly in youth than in adults and can lead to many years of use. And despite there being limited evidence base for youth cessation, there are some promising practices that are there to help youth quit tobacco. The best ways to ask youth about tobacco use? Well, first of all, universal screening is key. That helps counteract bias by ensuring that every patient is asked about tobacco, not just the ones who are presumed to be at risk of use. And we want to structure the environment to support confidentiality and encourage accurate disclosure. So this is a good topic to discuss with the teen during that time of the checkup when the parent is not in the exam room. And you can open the door of the conversation by asking first about use among friends or family, and then ask the youth whether it's okay to ask about their own use. So a sample question could be, do your friends or family use tobacco or vaping products? Have you ever tried them? Which ones? How many times or how often? There are also many different types of tobacco products out there, so you do need to use inclusive questions. For example, a lot of teens do not think of vaping as tobacco use. So you may get a more accurate answer if you actually ask about specific products. So an example question could be, do you use any tobacco products like cigarettes, vape pens, or Juul? And you're more likely to get an accurate answer that way. Another consideration is using a self-administered screening questionnaire. I think we're probably all familiar with the CRAFT questionnaire for which screens for drug use. There's also the CRAFT plus N nicotine. And some practices will actually have teens fill that out at the start of the visit, and that could save time during the visit. And there's some evidence that self-administered screening, we've seen this with PHQ-9s, for example, can be more effective in promoting adolescent disclosure than a verbal question initially. Once the youth responds yes, if they tell you that they do use tobacco, then that's when you begin to advise them on why they should consider quitting tobacco use. It's important to be clear, explain that their brains are still developing, leaving them uniquely susceptible to nicotine addiction and altering their brain's development. You want to be personalized, explain that quitting might benefit their other interests. For example, it could improve athletic performance or allow them to save money to spend on hobbies or other activities. And you can explain the benefits of quitting. Explain that quitting tobacco is good for health, saves money, and helps avoid things like exposure to toxic chemicals or metals or bad breath or stained teeth. And you can explain that quitting gives you more control of your life because you're not dependent on something. Also, really important to ask, why are they using tobacco? Young people may use tobacco products to self-medicate for anxiety or stress or depression. So if you discover that, they can talk with you about healthy ways to manage those conditions. You also want to assess their history of tobacco use. If they've ever tried to quit in the past, that can tell you if they might be dependent. And of course, you need to assess their readiness to quit. Some sample counseling statements. I know you run cross country. Quitting smoking can help your lung capacity, which can help you run farther and faster. That type of language really does speak to a lot of teen athletes. You've mentioned symptoms that happen when you haven't vaped in a while. Those are symptoms of withdrawal. So this tells us that you are developing an addiction. It sounds like you're vaping to deal with stress. Can I offer suggestions for better ways to cope with stress? And then anyone who's been trained in motivational interviewing would recognize these last few ones. On a scale of 1 to 10, how important is it for you to quit vaping? What made you choose that number? What might it take to get you to a higher number? Quitting is hard, but I believe you can do it. Are you interested in quitting today? Again, that's during a motivational interviewing conversation. The youth does indicate that they are ready to quit. Then what you want to do is actually help them set a quit date within 2 weeks. That's really the most effective way to get someone to quit, is to actually set a date in the near future. You do want to avoid major life stressors. Final exam week is not the time to get someone to quit. And you do want to explain that you will connect them with the behavioral support program that will help them develop a plan for success and anticipate any challenges. That part's key. The majority of what's going to happen with the teen cessation is not going to happen in the exam room with you. They're going to need behavioral support. So I'll get into more details on that. And I think it's important to encourage you to include parents in their quit attempt. So while you're having this conversation initially, confidentially, it's good to talk to you and parent together if the teen is open to that. You can help parents understand that tobacco use is not their child's fault. Nicotine dependence is a medical condition, and you're there to help. And if a parent or someone else in the household uses tobacco too, then talk to them about quitting together as a family. It's easier to quit when you can do it with a partner. And if the youth says they don't want to engage the parents, you still, of course, want to respect that. If a youth says they're not ready to quit, then offer them encouragement and just to show them that you're there to help when they're ready, and just make sure to make a note yourself to revisit that topic at the next visit. Or you could consider the 2-week challenge. The 2-week challenge is if a patient says they're not ready to quit, or tells you they think they can, but they just don't want to now, they could anytime they want to, then you could challenge them to completely stop their tobacco use for 2 weeks. And if they agree to that challenge at the end of that 2 weeks, you check in and hear how it went, and then you can revisit the conversation about cessation support. Or if they're not ready to stop for 2 weeks, you can even challenge them to try for 1 to 3 days. And sometimes that helps someone recognize that they actually do have an addiction. Now, moving on to tobacco cessation, if you have youth who is ready to quit and you're going to start the cessation process, there are both behavioral and pharmacological supports that exist. And again, mostly most of the ongoing long-term support and helping teens quit is going to occur outside of your clinic visit. There are quit programs that have expertise and capacity to provide youth who use tobacco with ongoing support. And really our goal is to connect you to those resources, follow up with them on their progress, and then provide additional supports if needed. Tobacco use is a chronic and relapsing condition, and quitting oftentimes takes multiple attempts. So the behavioral support is so critical. Behavioral cessation treatments come in different modalities. There's a telephone quit line, there's text message support, web modules, smartphone apps, or for more severe cases, there's in-person counseling programs as well. The elements of a successful program is they encourage teens to quit completely. So again, setting a quit date for 2 weeks, encouraging you to stop using all tobacco and vaping products, throw away all the products and paraphernalia at the start of their quit. Help them identify their triggers, those people, places, feelings that make them want to use tobacco, and develop a plan for how to manage those triggers. Identifying withdrawal symptoms, talking to teens about how they're going to experience cravings or irritability or an increased appetite, and just being prepared to manage those withdrawal symptoms. And helping teens identify friends and family who will encourage their success, and encouraging teens in self-care, encouraging things like mindfulness, meditation, or eating and exercise are all going to be important elements of a cessation support program. I put up here on this slide some of my favorite ones, the ones that I share and have smart phrases for in my EMR. There's the telephone quit line, 1-800-QUIT-NOW. That is a national 1-800 number that's run by the National Cancer Institute. And when someone calls it, it connects them to the state affiliate. And when you call this phone number, you get a personal counselor who will help you through your quit process. And it will be multiple conversations, and it is free. So 1-800-QUIT-NOW is for all ages. It's a really good program for people who would like to use phone counselor. A lot of teens, I think the majority now, prefer a text program instead. Text programs usually will involve somewhere between 1 to 4 texts every day for 4 to 8 weeks to help a teen through their quit process. There's smoke-free text, which is run by the National Cancer Institute, and that's just, again, teens can text quit to 47848. One that I like, particularly for youth who vape, is Ditch Vape, which is, or This Is Quitting is the name of the program. And that's run by the Truth Initiative. The Truth Initiative is an organization that focuses on research and communication to teens about tobacco and other substance use. Any commercials that you've seen encouraging teens to quit, or billboards that you've seen encouraging teens to quit, those are by the Truth Initiative. And so this is a text program that's specifically targeted to youth who vape. And the Truth Initiative also runs a text line for parents who want to help their child quit. Some teens will prefer a web module instead of texting. There's notforme.org that's run by the American Lung Association, and that's a 6-week program. Again, it's a free program, and that's doing some web modules every day for that full 6 weeks. And then there also is a smartphone app run by the National Cancer Institute called Quit Start, and that's available on both Apple and Android in their app stores. If you are initiating behavioral cessation support, teen is ready to go, then I'd say get that teen to sign up on their smartphone while they're still in the exam room with you. Or at a minimum, include the options in the ABS, or offer to send them a message via your patient portal. But you want to really get them to sign up for one of these when they're agreeing to it. Some sample statements is, you might say, quitting is hard, so I'm going to connect you to some help. Take out your phone right now and let's text quit to 47848. The counselor will follow up with you to make a quit plan and help you deal with your cravings and triggers. And I'm going to personally follow up with you again in 2 weeks to see how you're doing with it. I mentioned there's pharmacological cessation support too. It's important to note that the FDA has not approved tobacco cessation pharmacotherapy for youth under 18. So use by adolescent is considered off-label and does require a prescription. Now, if a parent is involved in helping the teen quit, since most of the products are available over the counter, the parent can purchase these for their child. But if a teen is doing this confidentially without the parent's involvement, then in order to get these products, they would need a prescription from you. And I should also note that if you use pharmacological support, then that should be in addition to behavioral support. Those behavioral support programs we just went over, those are still going to be critical whether you use medication or not. Now, one type of medication that is always by prescription for all ages are the non-nicotine ones, varenicline or Chantix or bupropion or Wellbutrin. Those are primarily to help with the withdrawal symptoms. So as we know, these medications can be used for depression, anxiety, but they are shown to be effective with helping with the withdrawal that you experience when quitting tobacco. But the AAP recommends that we pediatricians consider off-label nicotine replacement therapy for youth who are moderately or severely dependent on nicotine. There actually are screening tools that you can use to determine how severe someone's nicotine dependence is. These are all free to download online. There's hooked on nicotine checklists. There's the e-cigarette dependence scale or the modified figures from tolerance questionnaire. These are in questionnaires that you already know someone is addicted to nicotine and it helps you know how severe. So you could consider using these. But I would generally say that subjectively through conversation, you have a good sense if you have a patient who should be doing pharmacological support in addition to behavioral support. Let's talk about nicotine replacement therapy a little bit. The research on the effectiveness for helping youth quit is actually pretty limited, and findings that are available are mixed, showing that there's more modest outcomes than in adult trials. But the AAP statement that recommends consideration of off-label prescribing notes that there's no evidence of serious harm from using nicotine replacement therapy in adolescents, and there's plenty of evidence about the severe harms of tobacco dependence. So they still recommend we use it. And we know it's safer than tobacco products because it delivers nicotine without the toxic chemicals and carcinogens that tobacco products deliver. And there's a low potential for misuse because the nicotine is absorbed very slowly. When you're doing nicotine replacement therapy, the goal is to relieve withdrawal symptoms by providing a controlled amount of nicotine to the user. So best results occur when pairing a long-term form, a long-acting form of nicotine replacement therapy, which would be like a patch, along with short-acting forms, which would be like gums, lozenges, nasal sprays, or oral inhalers. That combination therapy is what allows the patient to keep a steady level of nicotine in the bloodstream the whole day, but also respond to cravings as they occur. I don't have time to go into full details about these, the different options of NRT, but I want to point out on the AAP website, there is a really good 2-page, easy to follow prescribing guide for nicotine replacement therapy that all of us can access. But for those of you who use Up to Date, I think their article on nicotine replacement therapy is great. They actually have one specific for adolescents. And so those are prescribing guides that you can very easily follow if you have a teen that you want to do this for. And I mentioned if the teen does it confidentially, then it needs to be prescription. And I know in EMR that I use in Epic in my organization, these products are actually loaded in there. And so you can also use Micromedics to look at prescribing information as well. Really important to do that 2-week follow-up that I've mentioned a few times now. 2-week follow-up of the quit date is so essential because this is going to be a long-term process, and that teen really needs to feel support from their primary care provider. Topics to discuss in that follow-up visit: do they stick to their quit date? Are they using the behavioral supports that you connected them with? Do they like them? Are they helpful? If not, think about switching to one of the other methods, since there are several different versions. Are they using the pharmacotherapy that you prescribed or recommended? Is that helpful? Are they actually using it the correct way? And have they used any tobacco products since the quit date? If no, that's awesome, and you want to congratulate them and encourage them to keep going. But if yes, then let them know that quitting is really hard and relapse is common, and you're not judging them for it. And ask for more details about when and why they use tobacco, and then try to devise a plan to how to avoid the next relapse. And just reinforce that it's not a failure; it's a learning opportunity, and that you still are confident that they can do it. Parents, we should be asking about tobacco use not just at our adolescent checkups, but also at our checkups with younger kids. And the reason for that is parental smoking is the main source of children's secondhand smoke exposure. And also we knew that parents who smoke are more likely to have teens who start to smoke as well. We also know that pediatricians have direct contact with about a quarter of the nation's adult smokers through well-child visits. And for our patients who are on Medicaid, many of their parents are uninsured. So we might be the only healthcare provider that they see all year, and we see them multiple times when their kids are young. So we may have more contact with them than any other healthcare provider out there. It's important when we have these conversations to focus on their child as the primary beneficiary of smoking cessation. Again, we are experts in child health and safety, so we want to couch this conversation in that. And if parents feel that they're ready to quit, then you can refer them to that 1-800-QUIT-NOW telephone line that we talked about. The web module and the American Cancer Institute text line are also for all ages too. So you can also refer them to there. Again, some of the lines that I share with you are more specific to teens. I'm going to make another abrupt transition to talking about food insecurity. So why do we screen for food insecurity? Well, 1 of every 5 U.S. children live in households without consistent adequate access to food. Children who live in households that are food insecure, even at the lowest levels, are likely to be sick more often, recover from illness more slowly, and be hospitalized more frequently. And lack of adequate healthy food can impair a child's ability to concentrate, perform well in school. It's linked to higher levels of behavioral and emotional problems as well. And it's important to note that food insecurity can affect children in any community, not just the ones that we think of as the underserved communities. It's a guarantee that all of us in our practice see kids with food insecurity. We also know that parents limit their children's hunger by strategically limiting their own intake and by feeding their children energy-dense and nutrient-poor food. And we know that early childhood malnutrition leads to adult disease, including obesity, diabetes, hyperlipidemia, and cardiovascular disease. We, as peer healthcare providers, play a central role in connecting families with needed community resources. That's what we do at checkups. So it's so important to screen for this. The best way to screen for food insecurity is something I think probably most of you are familiar with, the hunger vital sign. Where that comes from, the USDA uses an 18-item measure to assess food insecurity for research purposes. And the hunger vital sign is a validated 2-item screen taken from those original 18 questions. Affirmative answers either of the 2 questions identify food insecurity with a sensitivity of about 97%. So about as highly effective screen as you're going to get. The 2 questions are within the past 12 months, we worried whether our food would run out before we got money to buy more. And within the past 12 months, the food we bought just didn't last and we didn't have money to get more. So a yes answer to either one of those 2 questions would be considered a positive screen. If you do get a positive screen, it's important to know where to help families turn. One option is food banks and food pantries. These are funded by a combination of local philanthropic organizations, faith-based communities, and government resources. Feedingamerica.org is an online search tool that you can use to find local food banks and food pantries. And there's also the UCA National Hunger Hotline, which is in English or Spanish. It's 1-866-3-HUNGRY or 1-8778-HAMBRE. So providing those to families would be one way to help them find a food bank or food pantry. Of course, there are federal programs that mitigate food insecurity that I think we are all familiar with to some degree. There's the WIC, Women, Infants, and Children program. That's for pregnant women, breastfeeding women up to their child's 1st birthday, non-breastfeeding postpartum women up to 6 months postpartum, and children up to their 5th birthday. The income eligibility for that is less than or equal to 185% of the federal poverty level. There's SNAP, or the Supplemental Nutrition Assistance Program, formerly called food stamps, and that provides monthly benefits, usually via an electronic benefit transfer card now, to purchase eligible food items at retailers participating in the program. Most of our local grocery chains, even Amazon Fresh, all participate in this program. So there's lots of options for using that EBT card. And income eligibility is less than 130% of the federal poverty level. And then there's a national school lunch and school breakfast program. That's for kids 18 and under enrolled in school. They qualify for reduced cost meals if less than 185% of the federal poverty level, and free meals of less than or equal to 130% of the federal poverty level. Now, during the pandemic, there have been some expansions to some of these federal food assistance programs. SNAP benefits had increased early in the pandemic by 15%. That did expire in October, but thankfully, Congress did pass a new benefit calculation, and that new calculation is about a 25% increase over pre-pandemic levels. So actually, SNAP benefits now are even higher than they were in October. The WIC benefits for purchase of fruits and vegetables increased, and while some things unfortunately have expired, that has actually remained, so that increased benefit is still there. Many public schools began offering grab-and-go meals for weekends and school breaks, and with those programs too, the child didn't have to be present or even enrolled in the school. or sorry, didn't have to be rolled school, but didn't have to be present. And many schools are planning to continue that for next year, but that is a sort of individual school-based program, oftentimes run by PTAs or the administration. Here in Washington State, about 500 schools began offering free breakfast and lunch to all children, regardless of income status. And the reason they were able to do that is the USDA has the Community Eligibility Program, which allows schools with high numbers of low-income families to serve free breakfast and lunch to all students without collecting any school meal applications. So it's easier for families. You don't have to collect those applications. You don't have to track the exact numbers. At a certain level, a school will just qualify to offer free breakfast and lunch to all students. And in 2020, our legislature required all schools that are eligible for CEP to participate in the program, because many schools were eligible were actually not participating. We're still doing it the old way of collecting those applications and only offering it to certain students. With this bill passed in legislature in 2020, requiring schools to participate in CEP if the cost to provide free meals to the entire school was the same as it would have been to serve students who qualified, then they were required to participate. And with that, about 500 Washington schools participated this past school year. And more excitingly, in this past legislative session, House Bill 1878, which was sponsored by Representative Riccelli of Spokane, who's a wonderful advocate for kids. And this was a bill that the chapter had strongly supported, passed this last session. And what HB 1878 does is it requires all schools to participate in CEP if they're eligible. So again, before it was only have to participate if the cost was the same as if you did it the old way. But in the new way, if you're eligible, then you have to participate regardless of cost. And the bill requires the state to cover any excess costs. It also changed what it takes to qualify. So in this past school year, about 63% of kids at a specific school had to be eligible for the program to participate, but now only 40% of students have to be eligible to qualify. And a group of schools, so for example, a district can be eligible even if each school individually doesn't qualify. So if the district as a whole meets that percentage criteria, then all the schools in the district can qualify. We believe this bill is going to more than double the number of schools participating in offering free breakfast and lunch to all kids, regardless of income status and without applications this coming year. So probably about 1,000 Washington schools will be able to offer this coming year. Now, since either last week or this week is probably the last day of school for most of our kids and patients, it's really important to understand the summer food service program. This is federally funded by the UCA and it's administered by the Office of Superintendent of Public Instruction. And it's available to all children who would qualify for free meals at school. So now this is only going to be available to those students who would qualify rather than to the entire school population. The sponsors for the summer food service program get reimbursed by the program, and sites are managed in a variety of settings. There's schools, parks, community centers, some health clinics, hospitals, apartment complexes, churches, migrant centers. There's lots of different sponsors, and you can find those usually through the school or school district website or through the Office of Superintendent of Public Instruction website as well. Or also the USDA website has a search function by zip code as well to find these sites. Each youth can receive 1 meal per day to be eaten on site. This is a bit of disappointment. During the pandemic, we had a federal waiver, which the last 2 summers, parents could pick up meals at those sites on behalf of youth and then take the meals off site. And before the pandemic, youth had to be present to get that meal. And this summer, that is again the case. It's back to the way it was pre-pandemic. Well, I shared all these different resources with you, but this slide's probably the most important one because I don't think actually as pediatricians, we have to know any of those details. Instead, we can refer our patients to Within Reach. This is an organization that I'm very proud to serve on the board of. Within Reach is a nonprofit that aims to connect families to the services they need to thrive. We run the Help Me Grow hotline, and this is an important phone number that I think every pediatrician in the state should know because this is a statewide organization. 1-800-322-2588. If we have families call that number, there's multilingual staff family navigators that are ready to walk parents through which social support services they qualify for and actually help them do the applications too. And the family navigators also follow up with families to make sure that those services are accessed. So there is a closed loop there, which is really wonderful. We also do have the parenthelp123.org site. So for families who don't want to talk to Family Navigator on the phone, this website is an online search tool that uses the same comprehensive database that the Family Navigators access. So most of the resources that we talked about today can all be found from this website. And the real advantage of referring families to Within Reach is that many families with food insecurity also might have insecurity for housing or utilities, healthcare, transportation, and Within Reach will help families access support for all of those needs. So this really is really important for us to be able to share with families. With that, I think we've reached the time towards the end. We have time for questions. I'm going to just stop sharing my screen here and we'll open it up.
Hi, Ruben. So we have two questions in the chat, and one is from Sarah Rafton, and she's asking, since quitting tobacco is so incredibly difficult, are there modalities that pediatric primary care can implement to help teens more regularly than a return visit allows, like texting, like MA calling to follow up with them, apps that we can download with the teen in the office?
That is a great question. I think that definitely, can you offer texting directly from the clinic as opposed to through one of the behavioral support programs that I talked about? That's probably going to be dependent at the individual clinic and healthcare organization level. I know some organizations, only allow communication to be through their patient portal, for example, and don't allow texting due to concerns about security. Whereas I do know some practices that have actually determined actually a way to text with patients. And so certainly if that's something that your practice allows you to do is comfortable doing, that is another way that you could communicate with teens. It's definitely, I think, the preferred way for teens to be communicated with, but in some organizations, we're not able to do that. But a lot of teens can have access to a patient portal and also might access email or even get text alerts when they get a message to the patient portal. So that can be a workaround too. In terms of having an MA calling to follow up, that's also an option that could work. I think because it is so hard to quit, I think really having a personal advocate is important. And if your teenage patient does have a connection with your MA, if it's someone that they know and it's a familiar name, familiar voice, that can help. But if they don't have much rapport with them, then it's going to be much more effective coming from us. And so I think it's still really important for the primary care provider to be doing the follow-up. And I think if you can do, at least at that initial quit date, do a 2-week follow-up in person or do a virtual visit with them, I think that would really be the most effective. I think really doing that early 2-week quit date is so critical to success. And having like an actual visit with your primary care provider for that is really important.
The second question in the chat is, can you discuss the concerns, both legal, medical, with pediatricians treating a parent's tobacco use disorder? And then it seems safe to stick to treat simply with MI and suggestions to try over-the-counter nicotine replacement, but also what are the concerns with pediatricians taking on care for a medically non-complex parent on the single use and prescribing? It seems important to not simply refer a parent's own doctors, especially if they are not insured, do not have a primary care provider, live in a rural area, are concerned about their documentation status being exposed, etc.
Yeah, these are all good points. And some of our parents that we see don't have a primary care provider, so you don't have necessarily a PCP to refer them to. Sometimes you can try to get them established with a PCP when they're with you. It's certainly something that I do often with postpartum parents who don't have a primary care provider. Really try to encourage them to get one and make some specific recommendations for one. But we know that we're not all successful with that. Because the the nicotine replacement therapy for adults does not require prescription. We're not going to be doing prescriptions for parents. These are over the counter, and so I think recommending someone to consider that. I don't think that you have to worry about liability there, but I think the first step, if you have a parent who indicates that they are ready to quit, is to get them into a behavioral support program. So really encouraging calling 1-800-QUIT now. I think most parents really do respond well to having a telephone coach, and that's probably more effective for parents. And so I think encouraging that is really critical. If it seems like someone does have really severe nicotine addiction, I think really trying to encourage them to see the PCP if they have one. If they don't have one, encourage them to establish with one. So that you're not truly taking on the treatment. I think, with parents, you're primarily initiating the conversation, assessing readiness to quit. And if they are ready to quit, then really trying to connect them to the resources to help them do that, because you can't truly manage it. And quitting is a long-term process. There's likely to be relapses. It's going to be hard. And as you stated, you can't really be their primary point person to help them quit, but you really want to try to initiate that process. And then, we do lots of checkups with young kids. And so you'll see that parent again, and you can still check in with them. Did they accessing those resources? And if not, start that conversation again and really try to connect them to those resources. Let's see, I'll try to scroll the chat here to see if there's any others. I don't see any other questions in the chat. Any other questions? Anyone can feel free to unmute and just ask the group as well.
Ruben, do you have any stories or examples of resistance to firearm storage and sort of any breakthroughs that you had in that moment or over time? I think it can be a hard one, and I just wonder if there's any story you want to tell of kind of chipping away or having a breakthrough.
We asked the question initially on a written form. So when parents are checking in for an appointment for different ages, there's also different handout they get with the set list of questions that they answer. They're primarily yes or no questions, and then our medical assistants review those and enter them in the EMR. And it is actually quite common with that particular question about, do you have a firearm in your home? I think the question is there a firearm in your home or in a home that your children spends a substantial amount of time? And oftentimes people don't answer it. They leave it blank, or sometimes people will even write something like, this is a personal question, or this is none of your business. We'll see that a lot. And the MAs and our practice brought that up to us, like, it feels funny that we're asked this question, we get this response. However, I would say anytime I see that, I still bring it up with families, but sort of try to rephrase the question or explain why it's on there. So oftentimes, I'll say, I see you left this one blank, you didn't feel comfortable asking this, and just want to let you know that the reason we're asking it is because, of course, we're focused on your child's safety, and we're going to talk about a lot of ways that we want your child to be safe. And this is not specifically about knowing whether or not you own or use a firearm, but more about how do we make sure your child is safe if there's one that they can have access to. And it seems that phrasing it that way and just sort of coming back to it works really, really well. It's very rare where I get anyone who gets defensive when it's phrased that way or still refuses to answer. I have had, when I think over the last several years, I can think of 2 times actually, where someone still didn't want to answer. Like they didn't like that I was bringing it up when already they indicated on the written form that they didn't want to answer it. And in those cases, I didn't engage in much of a discussion. I just simply made a sort of blanket statement like, okay, W, I want to honor your feelings and don't want to talk about it. And this really all we were going to focus on was what safe storage practices and how safe enough guns in the home when guns and ammunition are stored along separately, and then just moved on. So sort of left it at that. But I would say those are really exceptions to the rule. While it's common for people to not want to answer the written question, and again, they might have a relationship with my medical assistant or don't feel comfortable putting something in writing, they still seem to be totally open to discussion when you really sort of start out by couching it in terms of child safety.
Thanks so much, Ruben.
Hey, Ruben, can you hear me?
Yes, I can.
Okay, hey, this is Thatcher. Thank you for covering all of these topics. I think these are really pertinent to all of our practices, and I appreciate the insight. So thank you for doing this. Just one thing to pass along. There is a ICD-10 for guns in the home not locked up, or something to that vernacular. So it's actually something I've found really useful when I'm addressing firearms at home. If there are firearms in the home that are not locked up, that you can actually put that in your problem list and be able to access that easily on subsequent visits, so that you know this is a family that's worth addressing this issue with. And if you have Epic, you just put in guns and it'll give you a number of options, but that specific option comes up. So just as a FYI to other people. And then a question for you, Ruben. Do you have recommendations on best places to go to possibly secure firearm locks for our practices?
Great question. So in other words, having some at your practice that can be distributed. I am.
Yeah, so that we can. Yeah, so we have like a stockpile that we could give out to families if needed.
Yeah, it's a good question. I am familiar of how that can be done here locally. So I do know that Public Health, Seattle, King County, through the Lock It Up program, if there are places like a clinic site that actually wants to have things like cable locks, for example, in their practice that they can distribute, they do have a really discounted program to do that, and oftentimes will even offer a certain number for free for sort of partnering with them and also sharing their materials. So I know that that's the case here locally. I'll admit I'm not aware of the options throughout the state. I do, wonder if contacting your local public health department to find out if they do something similar would be, might be a way to start. And that would be an interesting question too. I'm not sure if any of the chapter staff knows of other options throughout the state, or we might be able to find out from the WSMA staff if they know of other options. But I know that for those who are practicing in the Seattle area, definitely that what Thatcher was describing doing, the public health department will really help you do that. And so I would hope that there are opportunities like that throughout the state. Do any of the chapter staff know of any other organizations besides Public Health, Seattle King County that will work with clinics to do this? No, but yeah, thank you, Thatcher. If clinics wanted to do that, that is an excellent idea. And I have heard it at national AP meetings, some other clinics across the country that have done that actually have had cable locks to give away, or at least have been able to give like discount cards to retailers that sell lock boxes. That's not something that we do in my practice, but I do know some practices that do it, and it's a great idea.
Okay, great. Thank you.
Thank you. Well, I think we're reaching time. I don't see any other questions. Thank you again, everybody, for joining us early in the morning for this talk. And if you do have further questions later, feel free to reach out to me. Even though I'm no longer on the chapter board, my AV chapter email still works. So it's the same format as all the other chapter 7 board members. You're welcome to reach me that way, and I would be happy to respond.
Thank you everyone for coming today, and thank you, Rupen, for leading this important conversation. And we will see everyone at our next webinar. Have a great day.
Thank you.